Uh, One point about thoracolumbar junction, why we are talking about these fractures is because this particular anatomical area is very typical in terms of it's a junction between a rigid kyphotic spine, which is supported by the ribs, with the mobile lumbar spine. And whenever there is a trauma or whenever there is a big force acting in this junction, it is likely to cause fractures or dislocation at this junction. And that is why this anatomy is very important. Dr. Sudhir and Dr. Sural have gone through the neurological examination and also through the concept of spinal shocks. I'm not going to repeat, but at the same time, it is very important for the PGs to understand that the concept of complete and incomplete injuries. A complete spinal cord injury is something wherein there is a total lack of sensory and motor function below the level of injury, and there is no perianal sensation or voluntary anal contracture. Whereas in an incomplete injury, there may be some preservation. Why it is important to understand this concept of a complete and incomplete injury? Because it does have a huge bearing on how you are going to manage these fractures, what is your attitude going to be. And also talking about the sacral sparing, which Dr. Sudhir has well covered about spinal shock. So you must understand that before you label a patient as a complete spinal cord injury, you must make sure that he is out of spinal shock, because that will make a huge difference in his prognosis and also in probably the surgical scenario. The classification of thoracolumbar fractures has been being evolving over so many years. In the last 60-70 years, the classification is still evolving. And why do we classify these fractures? As we know, is basically to communicate with each other. The classification gives us the treatment guidelines, and it also tells us about the prognostication of an injury. And for thoracolumbar burst fractures, actually, these classification systems are actually the key to management principles. So for us orthopedic surgeons, these classifications have kept evolving right from the time of Boller, when he introduced the concept of mechanism, to the concept of stability. And over the years, we have come up with a number of classification, like the Nicol classification, or 2-column classification, or 3-column classification. And finally, somewhere in 1983, we started getting hold, and we started getting an understanding of what spine is about when the 3-column concept was introduced by Dennis et al., who divided the vertebral column into 3 parts. The anterior 2/3 was the anterior 2/3 of the vertebral body, along with ALL was the anterior column. The posterior 1/3 of the body, along with the PLL, was the middle column, and the post structures, everything behind, were the posterior column. Now, why I'm stressing on this part is because our management principles will depend upon the involvement of these 3 columns in different fracture patterns. So if we can identify these columns, we can identify injuries, how many columns are getting involved. They would guide us what we want to do with this with our patient. So we have discussed that neurology is one of the most important factors to make a decision. Column involvement or the morphology of the fracture is the second most important factor in deciding. McAfee also came up with a classification. Now, the third factor which we have been talking about, the load sharing classification, was introduced somewhere in 94. This is the time when the CT and MRIs were gaining popularity all over the world. And what this classification looked like, it was basically, it came in the era of the short segment fixations, which when they started failing. So what are short segment fixations? These were fixations wherein a screw was put one level above the fracture level and one level below the fracture level. And they started realizing that some of the cases were doing very well with a short segment, some of the cases were not. So they started looking at what cases were doing good, and they realized that with this classification, which he introduced, wherein he divided the fractures into three parts, depending upon combination of the fracture displacement, and kyphosis correction. And he realized that according to his scale, if the score was above 6, then these patients were likely to fail with a short segment posterior construct. So this was the load sharing classification, which came in 1993. The AO guys came up with their classification. We know how comprehensive these AO classifications have been. But the problem with the AO classification was that it could not be applied universally. It was too complicated, too difficult to remember. And there were a lot of studies which came in, which said, like this study by Honor et al., which said that there was a very poor inter-observer reliability. So now this brings me to the last 2 classifications. So you can sort of, if you think the previous slides have gone quickly and too fast, that's okay. You need to now concentrate on what I'm going to present, because these are the 2 classification systems now which are most in vogue, and these are the ones which really guide you in deciding what sort of management you want to do for a fracture. So this classification was introduced by Vaccaro et al. It's quite popular, which is called as TLIX, which was in 2005. And it looked at three factors. One, which we talked about, the injury morphology, how many columns, what type of fracture it is. Second, integrity of PLC. What is PLC? PLC is the posterior ligamentous complex. The posterior ligamentous complex is made up of the posterior supraspinous ligaments, the interspinous ligaments, and also the facetal capsules and the ligamentum flavum. So the integrity of PLC is the second most important factor. The third is, as we were discussing, neurological status. So how did he go about this classification and how does it help us in management? So they looked at morphology and they looked at compression fractures, which was simply end plate fractures. They gave them a score of 1. Then they classified burst fractures, which were not only end plate fractures, but were associated with the disruption of the middle column and were called as the burst fractures, wherein there is a classically there is a splaying of the interpedicular distance. The third type of morphology was translational injuries, as we see in fracture dislocation, which were given 3 points. And then fourth point was the distraction injuries, wherein the posterior ligaments may have torn in distraction, and this distraction injury may have come into the middle as well as the anterior column. These points were given according to the instability this injury morphology is creating. So a burst fracture would look like this. With on an X-ray, there seems to be a superior and inferior end plate fracture along with retropulsion of the posterior fragment of the vertebra, along with an interpedicular distance widening. If you look at the CT scans, you can see that there is a break in the vertebral body. There is a vertical laminar fracture, which is usually associated with it. So these were classified as the burst fractures. The other type of fractures were the translation or facetal dislocations, wherein the vertebral body alignment has changed and the facets have jumped or broken. And the distraction injuries were when there was interspinous widening, interspinous fractures or pars fractures on the posterior side, which means that there was the axis of rotation was in the front of the spinal column and the spinal column was opening from behind, which were called as the distraction injuries. The injury of posterior ligamentous complex was given different scores. If the PLC complex was intact, it was given 0. Suspected injury, 2 points, and then definitely injured posterior ligamentous complex was given 3 points. The neurological status again intact, because intact neurology was given 0 point. A complete injury was given 2 points, whereas an incomplete injury was given 3 points because it is more important and more urgent to operate in people with incomplete injuries. So this was the table, and they gave us the idea that if the score is between 0 to 3, a non-surgical option may be given, whereas the score is above 4, a surgical option can be given. Which means that if you have a patient with intact neurology, which means score 0, with an intact PLC, which means score 0, but a burst fracture, which means score 2, you can conserve this patient. But at the same time, if you have no injury in the morphology, which means score 0, but the PLC integrity is gone, which is score 3, and the neurological status is incomplete, which is score 3, then you have to operate that patient. So it gives us a lot of idea, although it does leave some gray zones. And because there were some gray zones and still the principles were not clear, the AO system, and this is the second classification which we must remember, this system came up with, has come up very recently, which is very comprehensive, and it is involving all the factors, like it involves the morphology, the clinical factors, and the inter-observer and intra-observer reliability with this is very, very good. This is the classification system which has been given by the AO. Now it looks very complicated, but if you divide it simply, it's very easy. So if we hide this area, these are the type A fractures, which you start from the above. These A0 is minor fractures, A1 is end plate fractures, A2 is both end plate fractures, A3 is an end plate fracture with middle column, and A4 is a both end plate fractures with middle column. So this is the progression from a minor injury to a severe injury, and these are type A's. As you go to type B, these are PLC injuries actually. So when you look at B1, it's a pure osseous injury, wherein the injury is happening right from the front right up to the back, and the posterior column is failing in distraction. B2 injuries are soft with bony injury, and B3 injuries are actually anterior hyperextension injuries. The last part of the classification is translation injuries. So any fracture dislocations, shear injuries, lateral translations are coming under this. The beauty of this classification is that as you go from A to B to C, the instability and the severity of the injury increases. So you know, when you say AO type C, you know you are talking about a bad injury. When you say AO type A, it's a lesser severe injury. Similarly, when you go from A0 to A4, you know that A0 is a minor injury, but A4 is a severe injury. So it's very easy to communicate, and the treatment also depends upon the classification. Then there are factors which neurological factors which gives different meaning to different neurology. Then there are modifiers about whether a tension band is broken, not broken. So it gives a lot of description and helps us in making a decision. This is the algorithm which they give for now going through the classification and deciding what you want to do. So you have to ask just 4 basic questions. Do I see any disruption in the alignment? If you don't see any disruption in the alignment, go to the next step. If you see a disruption, it's a type C. The second is, do I see a distraction in the posterior tension band? If there is a distraction, the tension band is broken, it's a type B. If it is not broken, then you go on to the next type, which is the type A. In type A, you see if there is a vertebral body fracture or not. And depending upon whether it is only end plate fracture or middle column fracture, you can divide them into compression fractures, split fractures, incomplete or complete burst fractures. So basically, going by the principles, all stable fractures.
Dr. Ankur, please summarize.
Yes, this is the last 2-3 slides, sir.
Okay.
So all stable fractures, which are the compression fractures and stable fractures, can be treated conservatively. However, unstable fractures, which are usually AO type B or C, or flexion distraction injuries or translation and rotational injuries, they will usually require surgery. So basically, we need to establish the stability part of the fracture. Stable fractures can be conserved, unstable fractures need to be operated. There are different decision-making factors as we discussed. How do you do a non-operative treatment? So if you want to conserve a patient, you can give him a short period of rest for 5 to 7 days. Then you can get standing x-rays at 15 days. And if these standing x-rays show that it is unstable, you go for surgery. If the standing x-rays are looking reasonably stable, you can brace them and continue these braces for 3 months. On the other hand, for surgical indications, anything which is type B and C, a loss of height of more than 50%, a kyphosis of more than 30-degree local kyphosis, or a canal narrowing of 50% requires surgery. The last thing about approach, majority of the fractures can be dealt from the posterior approach. There are certain fractures which are really bad, with really bad combination and the fragments getting into the canal and occupying a significant amount of canal, may need to be dealt with a combined anterior and posterior approach. But more or less, the workhorse approach for these fractures is posterior approach. The last slide is about the length of the construct, and with this slide, I'll end the presentation. So there has been a lot of talk about how much instrumentation needs to be done, what levels need to be instrumented. So classically, we have been talking about short segment fractures, short segment constructs, wherein the screw is put one level above and one level below the fractures. But we know there are high failure rates with it in certain classification types. So the concept of long construct came, wherein people started putting two level screws up above and 2 level screws below. The failure rate is down with these constructs, but the problem is they are too long. They cause a lot of stiffness and sometimes back pain to the patients. So now what is gaining popularity is the fracture segment construct, wherein we try to negotiate pedicle screws into the fractured vertebra itself and then put a level above and level below. So this gives us enough stability and at the same time doesn't compromise too many motion segments. So depending upon the neurology, depending upon the PLC injury, and depending upon the intactness of PLC, we can take a call what sort of surgery we want to do. I think I'll end up here. Yeah.
Thank you.